COVID-19 Global Conversations. I'm Matt Bouchonville. I'm a diabetes specialist at the University of New Mexico, and I'm one of the associate directors at the Echo Institute in New Mexico. It is such an honor to welcome Dr. Kedar Mate today, who is president and CEO of the Institute for Healthcare Improvement. Dr. Mate will be discussing steps for reopening during the COVID-19 pandemic. And before we get started, I want to remind the network that we have Spanish and French interpreter services available. So you can actually follow this conversation through an interpreter if you wish. Additionally, for the question and answer portion of this session, you'll be able to submit questions in Spanish or French, and the interpreters will then submit your questions to us in English. And so as a reminder, you can go, if you want to utilize this service, you can go to the bottom of your screen and click on the globe icon, interpretation. And when you click on that, it will give you the option to use Spanish or French interpretation services. And then you'll have the option to hear only the interpreter, or you can keep the English softly in the background if you prefer. So thank you very much for those services today. We have had over 900 people register for today's session, and we're grateful for the time that you've taken out of your busy schedules to join us today. I will be co-facilitating today's session with Dr. Sanjeev Arora. Sanjeev?
Hello, welcome to the Echo Global Conversations, and really honored to have all of you. My name is Sanjeev Arora, and I'm a gastroenterologist by profession and serve as the director of the Echo Institute at the University of New Mexico in the United States. Welcome. Over to you, Kedar.
It's a real pleasure for me to be here. My name is Kedar Mate. I'm an internist. I have an appointment at Weill Cornell Medical College, and but my primary role right now is to be the president and the chief executive officer of the Institute for Healthcare Improvement in Boston, Massachusetts. It's great to be with you. Thank you for having me.
All right, thank you. And we have some housekeeping items to review before we get started. Today's session will be recorded, and the video links and presentation slides for this session can be accessed on our webpage. We'll make sure there's a link in the chat box for that webpage. And please know that it can take up to 48 hours for the session to be uploaded, for our video team to upload the session so that you'll be able to review it. And then please note that all of the participants will be in listen mode only today. And then if you've joined us for a previous Global Conversation series, you'll recall that we organized these sessions, these presentations, into two parts. And after each part, there will be moderated discussion. And this is to optimize community participation. So please send us your questions during these sessions. And you could submit your questions through the Q&A icon at the bottom of the screen. So please submit your questions for the speaker through the Q&A box rather than the chat box. We have received already almost 200 questions, and we know that we'll be getting live questions today too. So thank you for all of your questions that you submitted during the registration process. We apologize in advance that we won't be able to get to all of those, but we'll do our best to get to as many as we can. And then please keep your eye on the chat box as well, because you'll see a number of links to resources in the chat box from our Echo Digital Librarian. And also at the end of the session, you'll see a link in the chat box that will allow you to complete a survey and obtain your CEU or CME credit. So I thank you for participating in that session evaluation as well. Because of the large number of participants today, again, we'll have everyone in listen only mode, but also we're going to ask that you refrain from answering questions in the Q&A box. Thank you very much. And without further ado, I think we'll go ahead and get started. And I'd like to further introduce Dr. Mate, who is president and CEO of the Institute for Healthcare Improvement. He also serves as the Chief Innovation and Education Officer at IHI and is a research professor at Weill Cornell Medical College. Dr. Mate's scholarly work has focused on health system design, healthcare quality, strategies for achieving large-scale change, and approaches to improving value. He is the recipient of the Paul and Daisy Soros Fellowship and has been recognized as an Aspen Institute Healthcare Innovator. Previously, Dr. Mate worked at Partners in Health and served as a special assistant to the director of the HIV and AIDS department at the World Health Organization and led IHI's national program in South Africa. Dr. Mate has published numerous peer-reviewed articles, book chapters, and white papers. He graduated from Brown University with a degree in American history and from Harvard Medical School with a medical degree. And again, Dr. Mate will be talking to us today about steps for reopening during the COVID-19 pandemic. So thank you, Dr. Mate, and I think we'll have you steer on your end.
Very good. Well, again, it's an honor. It's a pleasure to be with you. Matthew, can I just check that you can see the slides that are on the screen correctly? Is that the case?
Yes, we've got it actually.
Okay.
Thank you, Dr.
Very
Mate.
good. Okay. Very good. Well, it's a real pleasure to be with you. I am, as Dr. Bouchonville just noted, I'm an internist. So I just by way of qualification, I'm not an infectious disease specialist and not an epidemiologist. However, I work principally on health system design and design of quality and how to keep health systems safe and effective at any time, but particularly during this time. So that's the basis upon which I come to you today. I have no financial disclosures. There's nothing that I have that would compete or create a conflict of interest in this situation. I do want to add that this is fast-moving science. So I'm going to do my best to summarize some of the questions and some of the needs around and some of the science around reopening. But I do want to be clear that this is a fast-moving field. As we've all experienced over the last 6 months, every day, approximately 172 articles are published on COVID-19. That means between when I created these slides and today, there have been something like 1,000 articles that have been written about COVID, and I'm certain that at least one of them pertains to the topic at hand here around reopening. So with that caveat, I'm going to do my best to summarize the approaches that we take to reopening today, but with full knowledge that there may be items that are surfacing in the literature right now that will change this story. Here is the global situation as of this morning. Almost 30 million cases of COVID worldwide. The US leads that league table, that unfortunate league table around number of cases, as well as the number of deaths, with India and Brazil rapidly catching up, unfortunately, on the number of cases and number of deaths. We have nearly 1 million deaths. Every day, the number of deaths goes up by 6,000 to 7,000 worldwide. Very big impact, as all of you know very well, that has completely transformed our lives. The concept of reopening is a big concept that has really very far-ranging effects into almost every aspect of our lives. Concept is, it's also somewhat of a misnomer because in many cases, things were not closed to begin with. So we're not reopening them. We might be changing the way in which these activities functions. Everything from schools and colleges to health services, where we eat, where we play, where we conduct our recreational activities, travel, everything has been fundamentally altered by the pandemic, and how we resume those activities is important. If I had to convey, a wise professor of mine once said, convey what you want people to learn in the first few minutes because that's when you have their attention that's the greatest. So if I have to convey something to you and I want you to remember this one thing, it's the following, which is that there is no absolute way of staying safe during a reopening process as long as the virus is with us. And as long as we don't have a vaccine or some way of completely curing the infection. However, there are ways that we can stay safe during any reopening procedure. And they essentially boil down to the 3 interventions that you may see on the slide here. This image is from the Infectious Disease Society of America. It's a very useful image, and it basically contains those 3 steps. Wear a mask whenever you're going out in public. Wash your hands for at least 20 seconds and wash it with a alcohol-containing solution, a hand sanitizer that has an alcohol-containing solution and at least 60% alcohol-containing. This is important. Read the label of your hand sanitizer to make sure it has that in it. And then lastly, practice social distancing. There's been a lot of debate and discussion about how far is far enough. The bottom line is as far as possible is important. to try to maintain. And at least 6 feet is the guidance that is being presently offered by IDSA. When we think about reopening healthcare, before we get into the technical detail around what that means, it's worth reflecting for a moment on some observations about healthcare during the pandemic that I believe will be instructive for how we resume or reopen services that were not operating during the pandemic. These observations are based on a group of healthcare organizations that IHI has the pleasure of working with in something that we call the Leadership Alliance. The Leadership Alliance is a group of 47 US-based organizations and 37 organizations elsewhere in the world that works together to try to understand how we can pursue the common goal of improving population health. These systems very early on in mid to late February started to trade knowledge and information about what it would take for them to maintain healthcare operations during the pandemic. And these were some of their observations as things progressed through the pandemic. The first is that they all experienced a triple threat. They had both the clinical challenge of trying to respond to COVID, a very significant operational challenge on how to set policy and procedure to improve outcomes and to maintain operational health of the organization. And they faced significant financial challenges as service lines were closed and people were no longer able to present to the organization. They also faced a very different way of learning. This is on the positive side. They changed their approaches to clinical governance. I spoke to a health system in India recently. The leader of that system described the fact that they built a care protocol for COVID in late February. They sent it out to all of their treatment locations. And within 2 weeks' time, they had changed that protocol over 34 times. We heard this kind of clinical maturation time and time again. The ER community here in the US started a wiki. It had 1 page when it started. It had over 400 pages just a month later. The Brigham and Women's Hospital presented a COVID protocol site with 1 entry. Now it has over 21 chapters. We would never, I believe that clinical governance is fundamentally different going forward, that we will learn in this way about almost every clinical condition going forward. We also established a different pace of learning with regards to our daily management. We had very robust data systems that maintained and managed the care operations of a hospital. How many people were presenting, how many people were testing positive, how many beds were available in the ICU and in the regular floors, what was our PPE stock and our burn rate. This was daily, hourly management of the entire situation. And that, sorry, I'm getting a little bit of feedback here. And
yes. I'm sorry. I think we're having an issue with the interpretation services broadcasting on the English line. Well, is there something we can do about that? I'm asking our IT. Let's try that again. Thank you.
Okay. Okay. Let me keep moving. So I think this notion of having a vigorous, regular management system that was able to account for how the hospital was functioning on a regular basis was critical. We also found that there were very significant dependencies across the care continuum. Health systems depended on their public health systems to manage and maintain control of the epidemic, and downstream from hospitals, post-acute and long-term care centers to be able to take on patients that had recently been treated and effectively managed in the hospital going forward. COVID did something, I think, very notable during this time, which is that it really demonstrated, at least here in the US and likewise elsewhere around the world, that these cross-continuum dependencies were vital to ensuring that we had an operating system for health and healthcare around the world. Lastly, burnout and morale. Physical safety was tough before COVID. Psychologically, safety was difficult before COVID. But we saw even more challenges with burnout and morale during COVID. A famous case here in the US was the case of Dr. Lorna Breen from New York Presbyterian, who unfortunately committed suicide, and her family was quoted as saying she tried to do her job and it killed her as she took care, as she provided care to patients living with COVID infection in New York City. Burnout and staff morale were such a big problem that IHI actually started to create this notion of psychological PPE along with other organizations. How might we take better care of our staff and our families and our people during this time? And in this were various ideas like creating space for people to take the time that they need between work and life, pairing workers in a buddy system so that they could actually take care of one another, and ensuring people had access to the mental health services that they needed to have access to in order to make this work going forward. And then lastly, there was very significant economic and clinical imperatives to reopen, to resume non-COVID related care, opening operating rooms, for example, for what might be described as elective procedural service, but this was important on weekends, weeknights, nights, opening surgical centers. It is true that it was not just an economic imperative to resume and return, but it was also a clinical imperative to resume care. And that's because we saw very clearly at this time that we were missing strokes and heart attacks and urgent aspects of care that needed to be handled at this time. So there was not only an economic imperative, but also a clinical imperative to resume and reopen. So how do we do that safely? How do we manage the safe reopening of what I will describe as non-COVID-19 care? So here I'm talking generally about clinical care, broadly about clinical care environments, not specialty specific. There are specific guidelines from various professional societies available at the national level in your countries or at the global level, society by society, about how to, for example, do ENT care or gastroenterological care at this time. I'd urge you to visit those specific guidance and guidelines around how to do those for each specific condition or specialty. I'm also not talking here about COVID specific care, which has its own considerations. I'm speaking to you here about how to manage non-COVID-19 care, how to resume routine dental care, routine pediatric care, routine family practice operations once again. When you think about these types of clinical environments, there are 3 key points, which is a question around when to resume care, how to resume care, and what to do when staff ultimately may get exposed or infected. With regards to when to resume care, there will always be trade-offs. And the trade-offs basically boil down to these 2 questions. Will the patient suffer some form of harm or injury if the care is not provided? Will there be a negative effect if the patient doesn't receive the care? And that's balanced against what is the risk of receiving that care, which is understood through the second question. What is the level of current community transmission that is present in the environment in which care is intended to be delivered? So those are the 2 questions, and this basically leads to a question around how to reopen and when to reopen and what type of service to offer in your clinical environment. The CDC produced the Centers for Disease Control here in the United States produced a very useful framework for understanding these 2 variables. I'm not going to go through this whole table. It's in your slides that you'll have available to you that you can reference and look at carefully if you wish to understand it more thoroughly. But essentially, on the y-axis here are the potentials for harm occurring if the service is not delivered, meaning if the deferral of care is likely to result in significant harm. Suppose somebody's having a heart attack or an MI, deferring care is likely to have very significant harm, and therefore they need care urgently, all the way through an unlikely scenario in which patients are not likely to be harmed if the care is not provided urgently. So for example, routine primary or specialty care, routine screening for asymptomatic conditions, deferral or delay in service in these conditions may not result in significant harm. And then on the x-axis are the levels of community transmission, from substantial community transmission to minimal community transmission. In effect, the basic premise is that if the risk of injury or harm is very high to a person, if the person is having a stroke or a heart attack or an acute abdomen, the basic thesis is that we have to find the safest possible way of providing care without delay. And conversely, if the case or the care required is likely to be routine, primary or secondary care, is not likely to cause considerable harm, the first option is to try to defer the care until the transmission level drops below a certain threshold. And if it's not possible to defer care, utilize telehealth options. And then if telehealth options are not available, then the next best case scenario is to bring the person in under circumstances that are enhanced infection control procedures that I'll describe to you now. So in the event that you have to bring someone in to the office how might you do that, or into the hospital or the clinical setting? How might you do that most effectively and most safely? Here's the first way of doing that. In person, the goal is to enhance infection control processes and procedures, and that involves asking patients about their symptoms before they come in, and to reschedule any non-urgent visits, or to track patients that do have existing symptoms into the right care pathway so that they don't mix with patients that don't have symptoms right now. The second idea is to avoid waiting rooms as much as you can. Immediately room people if they come in a car or they come in on foot. After they go through the screening process, immediately send them into a patient room so that they can be checked in and most efficiently. Screen everyone as they come through the door for symptoms and temperature, and ensure your staff are also getting screened. This is important. Your staff should get screened at a minimum every day or every shift, and perhaps multiple times during the day and shift. Create a separate flow if you can for patients who are that have symptoms or are not feeling well, and those that are not experiencing well visits, if you will, that don't have symptoms or are not sick. And if you can, if the office space allows it, create one-way flow so that patients are not crossing paths and going in opposite directions, but in fact are flowing through your office in a way that doesn't allow them to interact again with patients that are going in an opposite direction, or staff that are going in an opposite direction. Masks at all times for patients and staff. That's known as source control, stopping the infection at the source if it is present. And then the standard PPE for healthcare workers in a office practice setting that are not dealing with COVID-19 cases is to wear a face mask and eye protection for all. It should be an N95 or higher level respirator if you're involved in an aerosol generating procedure. Last two things, hand hygiene at all times. This is common infection control overall. And then and the final thing is just to keep people that are not essential to the visit out of the office as much as you can. So if it's not a patient, please have them wait in their cars or wait at home and not visit inside the office at the time. I just wanted to make a distinction between PPE for non-COVID care and what we know is PPE for persons under investigation or PUIs and known COVID cases. Known COVID cases involve a face shield, goggles, a gown and gloves. A more thorough form of PPE is necessary if you actually believe someone is infected or might be under investigation as a suspected case of COVID-19. This is different from the PPE for those that are non-COVID care, which is important to remember. If you can manage it, and I think many places right now are optimizing telehealth. We have a very significant growth of telehealth and consumer interest, as well as providers now reporting far more telehealth than before. Our Centers for Medicare and Medicaid here in the US are now paying for telehealth services for over 80 different telehealth services in this country. As we think about how to do this, you want to build virtual visits into your care pathways, have a phone-based triage system, nurse-directed triage, that can identify cases that need to be seen versus those that can be seen using a telehealth opportunity. Set up the visits well, and then ensure, critically, when you conduct telehealth visits, you have to create a workflow around the follow-up from the telehealth visits. And very importantly, we're working right now on trying to understand the future value of virtual visits in telehealth. Will the payment incentives that CMS has put in place now remain in place here in this country going forward? I predict that some form of payment for telehealth will continue and be robust in the future because of its demonstrated value. And then the last thing just to say is prepare for the inevitable. Staff will be exposed. They may get infected in the future. It's important for us to know as we try to manage our workforce how to actually bring healthcare providers that have been exposed or have developed COVID-19 infection back into the workforce. And here, there's been recent changes to the guidelines, so I just want to go through these very briefly. For those that have mild to moderate illness or are under suspicion, you want to have them out of work for at least 10 days since the symptoms have first appeared, and at least 24 hours. And it's important to do both of these. It's 10 days since symptoms first appeared, and 24 hours since the last fever, if there was a fever, without fever-reducing medications. And all of their symptoms, cough, shortness of breath, whatever they were experiencing, has improved. If the healthcare provider had serious or critical illness, perhaps requiring hospitalization, the guidance has changed to extend the duration of the time interval from when symptoms have passed to up to 20 days And there's an additional suggestion to consult with infection control experts in your institution to verify that the person is safe to return to work. Lastly, there's been a modification that the test-based strategy, that means using an antigen or PCR test to help verify that a person is still shedding or not shedding. The recent recommendations from the US CDC is that we no longer use test-based strategies because in the majority of cases, results would exclude people from working who continue to shed detectable RNA in their PCR, but are actually no longer infectious. So these are the three kind of key points, if you will, that I just to highlight them again, that I want to share about reopening for non-COVID care. There's a series of trade-offs between patient harm if they don't get the care and what the level of community transmission is today. If we're going to reopen, we should try to do it as much through virtual visits, through optimizing telehealth solutions. But if you are intending to open the office practice at this time, then we have to adopt enhanced infection control and prevention practices, as we described earlier, and plan for a circumstance which may occur in which your staff are ultimately exposed or infected by COVID-19. So with that, I'm going to pause here and invite questions and any comments that folks have.
Right, thank you, Kedar. That was a really outstanding presentation. I wonder if for the discussion portion, if we could ask you to temporarily stop sharing your screen, and I've got a couple questions for you, Kedar. The first question is from Diane Mitchell in Greensboro. Do you have any predictions for how the winter might affect reopening in the healthcare setting?
This is like the $1 million question right now. How will flu season and how will various other respiratory elements interface or interact with COVID-19? There's lots of speculation about this at the moment. It's very difficult to say for sure how I think how this is going to evolve for us over time. In all likelihood, we'll see far more cases of suspected COVID-19, which will require exclusion, which will require exclusion from participating in various activities, whether it's school or your workplace or whatever the activities might be involved. And then ultimately verification that the patient either doesn't have COVID-19 or does, in which case, if they do have COVID-19, they'll have to go through the process that I just described, well, what to do when someone's infected. They have to be kept out of work for 10 to 20 days, depending on the nature of the infection, and then have to be 24 hours from the last fever without fever-altering medications, and their symptoms have to resolve. If they are not actually found to have COVID-19, if the individual is not found to have COVID-19, then it reverts to a kind of traditional viral infection, a non-specific viral infection, which is 24 hours of not having a fever, the typical guidance that we offer people in those circumstances before they can return to a workplace or to school circumstances. So it's a very good question as to, at an epidemiological level, I can't say for sure, and I think nobody really knows. There's a lot of speculation right now about just how much of an impact the various viral pathogens that we know grow and respiratory conditions that we know grow in the winter times, how they'll interface and interact with COVID. But right now that's in the domain of speculation and not necessarily verifiable. But I think almost everyone believes that there will almost certainly be a larger number of people excluded from either workplaces or schools or other activities that have been reopened because they'll be getting tested, waiting for results, or indeed waiting for the period of time to elapse before which they can return to their job or to their school.
Okay, thank you, Kedar. And thank you, Diane, for the question. There's also a question / comment from Moore Mungati. Thank you for this presentation. We have also noted that the use of simple arrows and signs in vernacular language help control flow immensely. I wonder if you can comment on your experience there.
Yeah, I think there's a lot of different ways in which people are controlling flow through institutions. There's always been, I think simple signage is really critical. It's actually very critical, not just for flow, but in general right now, the more we can do to kind of simplify the message around how to prevent the spread of COVID-19. It's why I like that IDSA image so much. It's just a very simple way of apprehending what are the 3 things that every person in the world could do right now that would dramatically reduce COVID incidence. But to the question specifically around how to manage flow best, signage, arrows, sometimes tape on the floor that guides people through a health center or through a facility, color-coded at times can really help. These are all the kind of reliability practices and flow-related practices that have been shown to be effective historically. There's no reason to think that they wouldn't be applicable and useful now.
Okay, and then thank you. And then here's a question from Elizabeth Finley. I work with intellectually and developmentally disabled people. I've been contacted regarding a client who has a deep and long-lasting fear of all kinds of masks, whether that be medical mask, Halloween mask, what have you. Any advice on providing services for this client? In my logic, using a shield alone might not provide adequate protection. Any advice would be helpful.
Yeah, this is a challenging question. You're right that the questioner is right to say that a shield does not confer the same level of protection as a mask, and it doesn't. The shield is essentially to protect your eyes and your other parts of your body from being exposed to viral pathogen that's aerosolized. The mask covers nose and mouth. More specifically, the shield on its own is not seen as being a solution independent of a mask. They're seen as working in combination, again, containing the source in different ways. That said, I think if the individual can only manage a shield, I would say that's still something. It's better than nothing. And this question around whether to mask, if individuals afraid or concerned about a mask, we can't. It's not a good idea to mask if you are or advise using a mask if the individual in question feels has a phobia of the mask or is fearful of the mask or does indeed suffer a concern about using a mask. So that the guidance is wear a mask if you can wear a mask, if you can tolerate a mask, and otherwise. I think the use of a face shield is reasonable, but for different reasons, not necessarily for the protection that a mask conveys. In that circumstance, I do everything else: wash hands, use a mask, maintain social distance, and try to avoid as much as possible public exposure for the individual in question.
Okay, thank you, Kedar. And thank you, Elizabeth. I'm gonna pass to you, Sanjeev.
Yeah, Kedar, that was a wonderful talk. Thank you so much for joining this conversation. I have a question from Laura Makaroff from Atlanta, Georgia, and from the American Cancer Society. And the question has to do with overcoming patient fear for engaging in care. I'll expand on I think she marked the question as small, but what we are seeing, Kedar, is that cancer screening rates are going down substantially. And in some instances, there are examples of how cancer is actually being diagnosed at a later stage because of this problem.
Right.
And so there is this risk that yes, we will actually we'll get less COVID-19, but more damage could be done because people died of cancer instead. So could you talk a little bit about that? How do you engage patients with that?
Yeah, that's exactly why I was describing the economic, but also the clinical imperative to resume. And I think it's a non-trivial issue. As you're saying, there's the cancer screening rate concern. There's the presentation later in the disease course. We have reports from a large health system that we work with that describes that the presentation acuity is higher in the emergency rooms for pediatric cases now. We've seen a drop off in myocardial infarction presentation, stroke presentation, very significant changes in the total volumes of some of these issues. And I think this is a real concern, which is why safe resumption of service is critical. So part of the thesis of this whole presentation, and the reason we're even having this conversation, is that there is now broad recognition that there is a need to resume elective. I think the way that we've been thinking about it is that these procedural services or these services that are like cancer screening, for example, is considered elective or discretionary. That's not entirely the case, right? That there are significant both treatment services that are necessary and important to achieve in a timely fashion, and preventive and promotive services that are necessary and important to achieve in a timely manner. And so the question really is about how do we reopen safely? And then to answer the questioner's real question, which is how do we get the public to gain confidence in the fact that the facilities are safe to return to and to get their care at. And there, I think that the use of very significant communication strategies are going to be vital for us to move this forward. We have to basically say to the public all of the things that we are doing in some detail, and then make it evident to them that we're doing these things in considerable with considerable attention to the safety and preservation of staff, patient safety during this time. So I think it's very important for us to both follow these guidelines that we're describing here, and convey the guidelines to the public that we are doing all these things, and that it is safe for you to come back to clinical management right now. But ultimately, as a patient safety expert, it is true that the only way, if you think about the top of the hierarchy of controls, for those of you that are safety experts and think about this all the time, the only way to truly eliminate the risk of harm is to not have the interaction in the first place. But that's not viable when you balance that against the real need for the services that you're describing. And so we have to find a way to safely take that, and this is a dual communication challenge. We have to convey to the public that these services, cancer prevention, basic primary preventive and primary care services, are necessary and important to get, and that we can safely deliver them through an enhanced set of infection control and prevention practices, or optimally through telehealth. I know that can't be done for everything, but it can be done for some areas, and we want to make sure that people have understanding that that's achievable in that way.
I think one can understand, Kedar, the reluctance of the patients, because think about it, the Institute of Medicine had a report that one jumbo jet was crashing every day, 1747.
Right.
Because we as healthcare systems were not following the quality protocols as well as we could have. So there is a lack of trust in the people on the hospitals and systems being able to really do a good job with this issue. And when their own health is concerned, I can see why they're a little bit nervous. That, of course, points out to the fact that, for example, I want to put a plug in that in about 2 weeks from now, we are starting a massive quality improvement effort in all 15,000 nursing homes. This will be the ECHO project that is doing that, along in partnership with the Institute for Healthcare Improvement, where we are going to try and bring mentorship and support for every nursing home in the United States. So if you in the audience work for any nursing home, please be sure to join that collaborative to really reduce infection rates in nursing homes in the United States. Let's go to the next question. It has to do with, there are so many different guidelines, Kedar. There's a guideline from the CDC, there's a guideline from CMS, their own public health departments are following guidelines. How should a clinician or an administrator or leader in a health system reconcile these and move forward?
Yeah. This is a very challenging, this is a great question. And it's acutely felt here in the US, I think, as we've experienced conflicting guidelines between federal and state and even sometimes local policymakers. Ultimately the way that may or may not be the case in other parts of the world. I know the US system better than others, so I just want to be clear about referencing here. The conflicts that you're describing are particularly acute here domestically in the US, but they may be, this theme might be present elsewhere in the world. It's not an easy thing to make sense of all these different pieces of guidance and these different guidelines that are coming out. My suggestion, and the way that we've been thinking through this, has been to look at all the guidelines side by side in various areas, and to try to see where, and unfortunately to try to dig back into some of the literature that substantiates those guidelines. It's also the case that they change very regularly. So you might want to look at the most recent version, whatever it is, from the relevant authority. And the fact is that local guidelines vary, not because they are trying to be different from the the national guidance, but because they are specific to the local community transmission levels. And the local, as I said earlier, a lot of the reopening guidance is based on not only the need and the risks to the patient if they don't get the care, but it's also based on local community transmission level. And that allows the local guidance to be a bit more focused about how to direct the activities of local organizations, bars, restaurants, gyms, healthcare organizations, et cetera. So I would pay very careful attention to the local guidance because it's in all likelihood building its guidance or referencing the national standard, but leveraging the local knowledge around what's happening in your environment around community transmission levels locally. So the answer to the question about how to reconcile is, again, it's a very challenging circumstance for everyone to be living with. The federal guidelines or national guidelines are being made to be relevant across the entire country. And I think they form a nice backdrop, a nice backbone for how to build your response. But then I would very carefully, I'd seek out the state and local guidance because that set of guidelines will likely pertain to local transmission levels and will help you make the determination about whether to resume X or Y activity based on the fact that your local transmission level is accounted for in your local guidance. And the last point I would just say is that your understanding time is important in all this. Things change very regularly, as I referenced earlier. So look for the latest, look for what's up to date, the most up to date information at this point in time. The guidance on when healthcare workers can return to work was just updated less than 3 weeks ago. And so just keeping an eye on the things that really matter and the guidance as it changes, because it will change relatively regularly, both at a federal level and also at a state and local level.
Yeah, thanks, Kedar. That question was actually from the US, from Elaine Williams in Athens, Georgia.
Yeah.
The last question that I'm going to ask is from Shirley Fanbule in Monrovia in Liberia. Is a fabric cloth mask a PPE?
Oh, that's a good question. So fabric cloth masks are known to not prevent the spread nearly as well as sort of surgical grade masks, and not nearly as well as an N95. So there's definitely a graded kind of evolution of masks, essentially, or masking. A scarf, which some people use, or a headscarf or a neck scarf, brought over the nose and mouth is not as effective from a expression of the airborne pathogen, as well as a cloth masks, and it's not as effective. Cloth masks are not as effective as surgical masks, which are used in hospitals and health systems, and neither of them is effective as an N95 or a higher grade respirator. But it is known that it's a bit of a balance between how well the mask is going to be worn and the type of mask that it is. And there's I remember the Massachusetts Department of Health produced a very nice image, perhaps we can find it and send it around after the meeting, of the relative effectiveness of a mask worn well, whether it was a cloth mask or a surgical mask or an N95. N95s tend to be a little uncomfortable, they're a little more rigid, but a cloth mask may be a bit more pliable and fit to the face better and be a bit more comfortable. So if patients are willing to use, or individuals are willing to use a cloth mask 80% of the time, and an N95 only 15 or 20% of the time, the balance of effectiveness may come closer to equivalent. So it's at a population level, if we look at this and multiply it across an entire population. So masks of any kind are something, are part of a PPE, but a cloth mask is going to be far less effective than a surgical mask and far less effective than an N95 in the clinical setting. So in a clinical setting, if you're a healthcare provider, you should be using at a minimum a surgical mask, and if you're using if you're conducting aerosolized procedures, an N95 or higher grade mask. Cloth mask for healthcare providers, insufficient. For people coming into your offices, for patients coming in from their homes, they should be wearing at least a cloth mask. They don't need to be wearing an N95, as that will again lead to the challenges around shortages with N95s and other such materials, which should be reserved for the healthcare providers conducting those kinds of aerosolized procedures.
Thank you. Over to you, Matt.
Right, thank you. There's a question about reopening in India, Kedar, and the use of telehealth in that setting. And Dr. Yash Javeri is asking specifically about whether you could comment broadly on the medical legal aspects that need to be considered when using telehealth, especially in the acute care setting.
Yeah, so to be honest, I'm not an expert. I certainly am not an expert in the use of telehealth in India and the legal sort of construct that might be present there. Broadly speaking, the telehealth activities that are being conducted here in the U.S. at least, and that I'm more familiar with, are covered under the same legal protections that a primary care visit or an ambulatory care visit would be covered under. So there's no distinction there in terms of the liability coverage. But I don't know the circumstances, Matt, in India, nor in the specific circumstance in which the individual is asking the question from.
Okay, thank you, Kedar. And an anonymous question: should asymptomatic clinic staff be tested in any routine way, or should they only have daily questionnaires?
There's no role for that at this time. There's no projected role for regular, routine, kind of asymptomatic screening of any group of providers at this stage, or any group of individuals. So there's no documented approach to doing this that is being suggested. In fact, again, as I mentioned earlier, that if someone is known to be infected or exposed, the guidance is moving away from test-based strategies because it will pick up RNA even after the person is no longer infectious. But there's no screening process that classically utilizes a testing alone at this stage. There are test-based strategies that people have been working through and thinking about, but again, the primary approach is a symptom-based approach to understanding whether or not symptoms, documented symptoms of respiratory compromise, as well as temperature, have been seen. Not temperature alone, by the way, temperature plus symptoms have been used together to indicate whether someone might be ill and might require further testing. That would then trigger testing, to be clear, to verify that a person is either exposed or infected.
Okay, thank you, Kedar. And there's another anonymous question. Could you comment on recommendations for cleaning the offices between patients?
Yes, clean the office between patients. Sort of there's a variety of approved disinfectants that are important to use and to disinfect the rooms in between rooming patients. So when one patient exits, the surfaces, all of the doors, handles, the bed if there is one, or the seat, the chairs, any sinks or any sort of touch surfaces ought to be thoroughly cleaned with a solution that's approved for appropriate disinfection of the environment. And that should happen between every case. So again, procedurally and from a timing perspective, you have to allow for that kind of cleaning procedure to occur between patients in the clinical environment. So add that, extra time and I can see that the librarian, Ken, has put into the chat here the specific guidance around the disinfection of sites. That's exactly right. So follow those guidelines and conduct that kind of disinfecting between patients in your facility.
All right, thank you. And Kedar, I know you were about to transition to reopening of schools, so I'm going to ask one more clinic-based question before we segue. This is a question from Sheila Seitz. After administering an aerosolizing procedure, what steps should be followed before someone else can enter the room in which the aerosol medication was given?
This is a good question. I think again, the guidance that the chat function will now contain around this will also have a link to the aerosolized procedure guidance, which will contain sort of the information about how to ensure the room is clear. And again, when you're doing the aerosolized procedure, there's ways of containing the aerosol that limit the spread of the aerosol into the environment environmentally. That ought to be considered and used if possible. Again, if the supplies and the materials are available for doing so. But assuming that it is, there are specific procedures around how you maintain cleanliness of the room and the operating environment in which an aerosolized procedure was conducted. And again, that ought to be in the guidance documents that were just provided.
Okay, great. Well, thank you, Kedar. Thank you, Sheila, for that question. And I think we'll go ahead and transition then to reopening of schools. If you want to share your screen again, Kedar.
Great. Okay, so let me just bring this back. So the idea here, there are obviously many other. Okay, let me just make sure. Matt, can you see the screen? Is it? Let me just make sure you can.
It looks great, Kedar.
So one of the other things that Dr. Aurora and Dr. Bouchonville asked me to consider responding to was a broader understanding of reopening, not just our clinical environments, but our public environments more broadly. And because it's September and at least here in the U.S., the start of the school year, I thought that maybe a focus on one of the environments that is affecting so many people right now would be worthwhile to get a little bit more specific, because there are the guidance around reopening restaurants and bars and gyms and parks and beaches. They all vary somewhat. Again, they all follow the basic notion that we should be wearing masks at all times, maintaining social distance, using hand sanitizer and hand washing practices and procedures. But to be more specific about one environment, I picked schools to help us talk through what reopening processes and procedures look like in the school setting. So let me just for a second, forgive me for those of you that are from non-US settings, several of these slides will orient towards some of the statistics and data from the United States, but the message around what to do around schools is a global message. But some of the data and the stats here will be US focused. So in the US, we have a very large, the impact of school closure and the schools not being open is enormous. We have 80 million or so students affected by school closure. It's about 60 million in the pre-K to 12th grade years, and about 20 million students in college at the moment, or roughly speaking, in 2020. We also, just important to note that it's not just the students, of course, who are impacted by all of this, but we have 27 million workers in the US who depend in some measure on schools for their childcare. So that's, how they go to work, is that they have their kids in school all day and they don't need to hire someone else to take care of their kids. We also, importantly, there's another key constituency involved, of course, in schools, which are the school teachers. 3.7 million school teachers in the US, and many additional staff. I couldn't get an accurate estimate on the numbers of additional staff, janitorial, food service, administration, et cetera, that are involved in keeping schools open right now, were they to be open in a normal way. So the impact is very significant here in the US. It's up to a third of our country is involved in some way in the schooling process, and that, I think, is just a huge part of our economy and a huge part of our country's work. There are 7 kind of key points. Like healthcare, there's several key points about how to reopen schools. And so I'm going to run through these again relatively briefly and try to make some key points around each of these. There are trade-offs and choices about how to reopen schools. Outbreaks will occur, and how to manage them is going to be critical. We'll talk a little bit about the relative risk of death of flu versus COVID, which has been in the media and been talked about a lot. When to reopen, how to reopen, what's going to happen with inequities as public schools tend to be closed and private schools may reopen sooner. And then again, a little bit of the same theme from the previous bit around healthcare. What do we do when something happens, when we end up needing to go back to a closed school if the school opens? So the first point here is that is about trade-offs. And schools are, and other facets of our lives, it's not a sort of blanket reopening. The notion of reopening is sometimes, the way I hear it talked about often, is it's talked about as almost as if we reopen everything at once or we reopen nothing. And it's not that. It's not a blunt instrument. You can reopen schools and keep bars and restaurants closed, or parks and beaches closed. You can reopen schools and keep gyms and hair salons closed. You can reopen salons and keep everything else closed. It's a matter of kind of choices that every society is making at the moment around what to do. It's also a choice about the different grade levels in schools. And again, I'll use the shorthand from the US, our context and our education system, knowing full well that there are different versions of education systems out there in the world. But there's a difference between what we call elementary school, or pre-K through 4th or 5th grade, middle school, which is 4th or 5th grade to 9th grade, and then high school, 9th grade to 12th grade. again, reopening doesn't mean reopening all grade levels simultaneously. There can be a variable way in which we reopen. It's not all or none. And it involves a set of choices and trade-offs that we'll get to in just a moment. What we know about how COVID-19 spreads is important. COVID-19 spreads, as you all know, or many of you will know, person to person through contact, through respiratory droplets, from speaking, coughing, and sneezing in close proximity. We know that the symptoms occur a couple of days after exposure, which means, and that people don't need to be actively symptomatic in order to spread the virus, and that it's better and more efficient. Spread is better and more efficient in enclosed spaces with close contact for prolonged periods of time, defined as being closer than 6 feet for more than 15 minutes. For example, in prisons, nursing home, group homes, and indeed in schools. So knowing this about COVID-19, all of this is predictable, which is a second key point. Outbreaks will occur. And we saw in the last couple of weeks as schools have reopened here in the US that there have indeed been a number of outbreaks that have been occurring in schools. There was a report last week that there have been up to 80,000 cases of COVID associated with school reopening. And I'm sure that number, it's just an estimate. I'm sure that number will go up and will change over time. This is not surprising, but just as many of these stories that hit the press and are becoming, gaining media attention, there's also a lot of stories about how outbreaks are not occurring. And we don't hear as much about those because they're not necessarily newsworthy, they don't get a lot of attention. But there is, to be sure, a number of schools that are reopening and are doing so safely. And I just want the second key point here is that yes, outbreaks will occur, it's inevitable. The question is what we do when outbreaks occur and how we manage them. And how do we tell the story about the fact that there are a lot of schools that are opening where outbreaks are not occurring at this point in time. Third key point is that there is a question about the relative risk of death from influenza or pneumonia versus COVID-19. And I think you've all probably read and heard that the incidence of severe or fatal disease in children is considerably less than what we've observed in older adults and in adults in general. And here is one way of seeing this information. The way this slide is organized is assuming that there are 200,000 total COVID-19 deaths. And again, that's a big assumption, but assuming there are, what you'll see is that the greater risk of dying of influenza or pneumonia occurs between in neonates and infants, in early school age, elementary school age children, all the way through high school. The transition point is around age 25, when the risk of COVID death exceeds the risk of death from influenza. And so again, the key point here is that you have a very significant difference between how adults experience COVID and how kids experience COVID during this time. We do know that there was a study last week from DC National, from Children's National in Washington, DC, a cohort study reported in JAMA, 315 COVID positive cases, 1,400 cases with flu. And there was no significant difference in children of hospitalization, ICU, and mechanical ventilation for these two conditions. So there was, again, the possibility of children escaping significant risk is present as we consider the question of whether and when to reopen school. However, there is a bigger concern, which is that kids may transmit the virus to teachers. 30% of teachers are over the age of 50, and if you look at this graph, they clearly fall into considerably greater risk of COVID infection and risk of death. 51% of teachers in the United States have risk factors that would increase the risk of severe COVID-19. So they have risk factors that would lead them to significantly more severe COVID infection if they were to get it. We know that there are case reports from schools in Europe, in Sweden, where teachers died in May when schools were kept open. We know last week, for example, there was a teacher in South Carolina that died of COVID. There have been at least 3 that have been reported in the press that have died, 3 school teachers that have died since school has reopened. It is hard to know whether or not those teachers contracted the virus in the context of their school exposure, or whether or not they contracted the virus in their normal course of life, in their home life, or in their other public engagements. And so it's very difficult for us to tease out. It's not causality, but there is some level of association here that's worth understanding. There have been, I just want to make one last point here about the risk of infection. There have been early studies, there were early studies initially that showed that children were a third to half as likely to contract the virus. There were a lot of theories about why this was the case, suggesting that children had lower viral loads, smaller lung volumes, even theories like they were closer to the ground and therefore their expectoration would not lead to viral aerosolized trajectory that would result in transmission events. Largely, these theories have been debunked and or seriously called into question, at least. And it's more likely that lower incidence rates among children had to do with the fact that school let out in March and April, and that there were less frequent socialization, more social distancing during that early period. So just to be clear, it's not really entirely clear why children have lowered rates of infection, or at least lower acuity of disease. And in fact, their relative risk of contracting the virus may not be that different from other age groups overall. The fourth point is when to resume or reopen school. And this has been the subject of considerable debate and discussion here in the US, and I assume, and I know elsewhere around the world. There are various sources that have established thresholds from when to reopen. CDC, local state governments here in the US, federal government has not issued a blanket statement, but state governments, local municipalities, every school district has started to consider what thresholds they might employ when thinking about how to reopen their schooling systems. Most of those thresholds are based on essentially two primary measures. One is an incident rate per 1,000 members of a community. Both of the measures, by the way, are about the relative prevalence of the disease and the relative incidence of the disease in the local environment in which the school is situated. So the first is incidence rate per 100,000, and the second is a 7-day rolling average of test positivity. How many people in the environment are testing positive? And they establish essentially two pieces of understanding. They understand the prevalence of the disease locally and the trajectory of the disease. Is it growing or is it shrinking? The emphasis in this, on the right side of the slide, is guidance, sort of summarized guidance from the Children's Hospital of Pennsylvania, the policy lab there recently in August. They basically suggested if the level of incident cases was dropping below 10 per 100,000 and the total prevalence of test positivity was less than 5%, that was essentially safe territory to resume schooling, to open schooling for full in-person or if preferred hybrid instruction in compliance with state and local practice. And again, in the middle, if the case incidence was between 10 and 35 per 100,000 and less than 5%, that's where you could choose an incremental strategy, which might involve reopening elementary schools where children are likely to have a much greater difficulty in accessing virtual or online options while keeping the high schools closed. If you have a stable incidence and positivity rate of between 5 and 9% or exceeding 9%, that's where you get into the need for virtual schooling and trying to keep your in-person options closed. There are lots of questions I know about extracurricular activities, about sport, about music, and perhaps in the Q&A we can get into some of those if people have questions about those areas. I'm just offering one map. This here is every county in the United States, color-coded. The Harvard Global Health Institute created this map, which was published in the New York Times here in the United States. Red indicates a place where schools should really not reopen. They should go to virtual options if possible. Orange and yellow is where hybrid options probably make the most sense. And green is where it's possible to reopen safely with a full-scale in-person instructional environment. So you can see the vast majority of our country here in the United States, and this will vary country to country, fits into the, geographically at least, fits into the range of needing to keep schools closed at this time and go to virtual options for schooling at this time. So how, if you're going to reopen school, how should you or how might we reopen safely? And here, this is the guidance. I'm using here the hierarchy of controls, which for those of you that are familiar with the patient safety literature and the overall safety literature, the industry safety literature, it ranges from most effective ways of controlling issues that might lead to risk and harm to the least effective ways of managing or controlling risk and harm. The most obvious way of eliminating harm is to eliminate the possibility that children go to school. Now that creates other risks, I would argue, but the risk of COVID infection from school is eliminated if kids don't go to school. On the other hand, it creates new risks. In our country, kids get a lot of their nutrition from schools. Obviously, there's the risk of them not learning what they need to learn in order for them to advance themselves and have successful lives and careers in the future. There's the risk of harm that might befall a student in school for whom going to school is actually safe haven, and they are leaving a risky environment in their home environment. So elimination of the risk of COVID may lead to other risks downstream. But I just wanted to make the point that if you were truly trying to maintain complete safety and eliminate the risk of infection at all, you would simply not have in-person education or in-person instruction in schools. Substitution is the second way of maintaining control. And a lot of what we're talking about right now is substituting virtual learning or hybrid learning environments for in-person school. That's replacing the hazard, if you will, by finding a safe way of conducting the way of thinking about how we educate. The bottom three, engineering controls, administrative controls, and PPE, is what we really mean when we talk about how to reopen in-person instruction safely. And here, I've just put on the right side of the slide some of the strategies that have been recommended and have been followed by CDC and other local school districts and education officials for how to reopen schools should you choose to have an in-person environment. The ways to do this is through some form of symptom surveillance. Symptom surveillance, importantly, is not just temperature checks as you walk through the door. It's temperature checks and an understanding of whether an individual student has experienced, symptoms of respiratory compromise in the last 24 to 48 hours or malaise. Two is maintaining social distancing within your classroom environments. There's lots of creative strategies that people have talked about doing so to try to maintain social distancing. This gets really hard when you have very large class sizes, 40 or 50. I've seen in the comments section, even for this session, that there are African and Asian schooling environments in which there are 40 or 50 students per class. How do you maintain social distancing in that environment? Very, very challenging to accomplish. We understand and recognize that. But that is one of the strategies to maintain and reopen safely. Cohorting in pods has been talked about a lot. Denmark pioneered this back in April, May, when they resumed the school year at that time. But the whole idea here is to limit the exposure of children to just the group that's in their classroom. Don't have them mixed together in cafeterias or in recess time with other cohorts from the same grade level or across grade levels, but keep them contained within a cohort or within a pod, so that if somebody gets infected, you can dismiss or move that pod or cohort to virtual instruction, but keep the rest of the school open for in-person education. Four is staggered transitions. Don't allow the cohorts or pods to interact with each other at lunch or recess and move between each other differently or more effectively. Hand washing and disinfecting, very important. Masks for kids at all times, respecting the comment and question earlier about sometimes children or other individuals might not be able to maintain a mask on their face, but to the extent that you can, the vast majority of kids have so far tolerated masks, but we do recognize that some will not be able to. And for those individuals, online instruction may be more appropriate to conduct. This idea of disinfecting between activities or cleaning between activities, same kind of rule, but as we talked about with healthcare settings, after a group has left the playground, for example, disinfecting the equipment so that the next group can come in. And again, that source control is maintained around the cohort that just left and the cohort that's coming. Increasing ventilation doesn't necessarily mean changing your HVAC systems, but it does mean opening the windows and doors and creating as much outdoor time for classrooms as you can and as weather allows. This will get more complicated as weather gets colder, but the desire here is to increase ventilation as much as possible during this time. And then lastly, some primary preventive and responding activities, ensuring vaccinations, of course, for folks so that you don't get into the situation where you've got a lot of flu coinciding, if you will, or other respiratory elements coinciding with COVID, raising the specter of COVID, even as it is not present in the individual in question. And then augmenting school health services, because they're going to have quite a bit of volume coming to them, as you can imagine. There is awareness that there is some possibility, by the way, And actually, there was a notes in Massachusetts, a case report, a case series in Massachusetts that showed that indeed, even as all of these primary prevention tactics went into place, that some of the traditional viral elements, flu, croup, bronchiolitis, et cetera, they went away during this period. But now, as we return to school, we may see some of these rebound in the near future. The sixth key point is that it's likely that we'll see a greater inequities arise. I don't want to let this really important social phenomenon escape us before we close this session with a comment here, which is that when we look at the readiness of schools to reopen, if you will, we notice, this is using the Harvard Global Health Institute data, we notice that the whiter the school district and the richer the school district or the counties, they appear more likely to reopen sooner. And that is likely to exacerbate, especially if the conditions remain in place for a long time, it's likely to exacerbate existing inequities, at least here in the United States and likewise across other parts of the world. And so just understanding that and ensuring that we take action to try to balance the educational opportunity for those that may not have their school systems reopen for in-person instruction is going to be really important and essential. Lastly, prepare for the inevitable. It's highly probable that at some point this year, we're going to have a scenario in which a student contracts the virus or indeed contracts or has symptoms of the virus and we need to know what to do and when to do it, just as we did with healthcare workers. So on the left is when we actually have cases. So if a case occurs in a family member of a student or the student themselves, then it matters what kind of circumstances you've already created for your student. If you are in in-person instruction mode, if you have classroom activities occurring, you've got to dismiss that cohort or that pod, that classroom for a few days to clean and disinfect everything thoroughly that the student may have had exposure to or contact with, and to conduct contact tracing with all of the individuals in that cohort and that have been exposed to that student or that individual. If you have a transmission event occurring, meaning a student passes it on to a staff member or a student passes it on to another student, you have to close at least that pod and likely perhaps even that school for a minimum of 14 days to effectively quarantine everyone and reduce potential further exposure. And if the county that the school is in is experiencing a resurgence or growth in the rate of infection, it's likely that time for quarantine will be extended to up to 28 days. Again, guidance here from CDC that I think is worth tracking and following closely as things evolve. On the right side of the slide are what to do when you don't yet know if you've got a case. You've got a symptomatic child and that child either tests positive or isn't tested yet. If they test positive, exclude them for 10 days from the symptom onset and at least 24 hours from fever resolution without fever-reducing medications, and conduct the activities over on the left in terms of short-term dismissal and cleaning. If the child has not been tested, we'll get them tested. If they refuse testing for some reason, you've got to still exclude that child for 10 days from symptom onset and at least 24 hours after fevers and symptoms resolve. If you have a symptomatic case, respiratory cough, shortness of breath, respiratory symptoms or fever, you want to, but you document an alternative cause. Their viral swab comes up positive, or they have an ear infection or something along those lines. You want to then proceed to exclude them until they're afebrile for 24 hours, kind of a more traditional what you do when someone has a fever or when we're not experiencing a pandemic. And then when someone is exposed but they're asymptomatic, you have to actually exclude them for 14 days from the last time of exposure, or from the last time when if they develop symptoms, then you go back up to number 1 or 2 when you either test them and they have a positive test or otherwise. So those are the actions to take when someone is actually infected in those circumstances. So these are the 7 key points about reopening schools. Trade-offs, outbreaks will happen, be prepared for them, but there are a lot of cases in which schools are proceeding without such outbreaks at this point in time. It is true that the relative risk of death of flu is greater in younger kids versus COVID, but there are risks to teachers and to adults at home that the students will return to. We talked about ideas and strategies for when to reopen based on cases per 100,000 as well as overall prevalence rates. And we talked about how to reopen with strategies to mitigate any kind of virus that might occur with screening, with enhanced cleaning and infection control and source control procedures like masking and social distancing. Inequities are going to grow, unfortunately, are likely to grow unless we take clear action to try to mitigate the consequences of richer counties and whiter counties opening or reopening sooner. And we should be prepared for cases that will come our way, unfortunately, and plan for those cases accordingly. So with that, I'm going to turn it back to you, Dr. Bouchonville, and we can go from there.
All right, thank you very much, Kedar. This is such an important topic, and we're getting a lot of questions. The first question is from Alaya Ambreen. Considering that kids are often asymptomatic from COVID-19, what implications are there for keeping the family members safe during reopening of schools?
Yeah, and it's a great question. And as I was saying, earlier, the best thing to do when somebody's asymptomatic, and kids are, as the questioner asks, often asymptomatic, the goal is to try to understand whether or not they do in fact have the infection. And there's not a lot that you can do. I mean, in close family living quarters, I think it's very challenging to keep people separate from one another. That hasn't been shown to be terribly effective. But if somebody is exposed to somebody with the virus, or indeed, and exhibits no symptoms, the guidance is to try to maintain at least 14 days of separation from the individual in question. That may not be practical, especially for young kids and for family members, but to the extent that you can, maintain social distancing and proper masking and hand sanitizing, everything else that we talked about earlier, even in the home environment, that may mitigate the risk, but it will be very challenging to do this, to maintain the kind of distance that one might need to accomplish. And of course, many transmission events have been documented in the home environment, probably the most of any other circumstance. But ventilation, masking, infection control processes, even in your home, is as best as you can probably do to try to mitigate the risk of transmission events occurring in the home.
All right, thank you. And there's a question from Melvina McCabe, and you touched on this, Kedar, but I wonder if you have any ideas. How is control going to be adjusted in the winter months when incorporating outdoor activities is less feasible?
Extremely good question. I mean, it's very, very challenging to know exactly how to do this. I think a lot of the control steps will remain. So again, the masking, the social distancing, the separation or the cohorting in pods. None of that is really environmentally dependent, right? The things that are very environmentally dependent are the ventilation, for example. Giving people more time or exposure to outside of the classroom type activities, those are going to be, affected by what we're seeing. I have seen some strategies that schools have been starting to talk about where they deliberately go to a more hybrid schedule in the winter, so that they can create more separation and more distance. And so they employ the kind of regular in-person up to a point when the weather becomes unmanageable, and they start to reduce the size of the classrooms and alternate schedules and create more of a hybrid learning environment as weather cools and it becomes more difficult for us to keep people in the schooling environment in a socially distanced manner going forward. The other complication, of course, that we referred to earlier in the prior discussion is, of course, the rate of respiratory illnesses are known to grow in the winter months. And that's going to lead to, I think, a variety of times when almost inevitably, we're going to see symptomatic cases that require response in schools that might lead to increasing rates of sending kids home if they were in person and transitioning to hybrid type activities. So the schools, if they aren't prepared for, a clear, if they are in person right now, they should have an action plan for how to respond to cases as they present and or symptoms as they arise, and to cold weather as it surfaces. All three of those need sort of mitigating approaches that largely will rely on movement to hybrid to try to reduce the number of people exposed in school.
Okay, all right, thank you. And Next is a question from Jennifer Clark. What is recommended for students who demonstrate COVID-like symptoms, but they test negative and they have no other identifiable cause? Should they complete quarantine, or should they be allowed to return to school?
It's a good question. So they've tested negative, but they are not, they're symptomatic, they've tested negative, if I understand the question correctly, but there's nothing else that we know about, like there's some viral pathogen NOS. The specificity of the viral tests are pretty good, for COVID. The sensitivity is reasonably good, but it's not perfect, to be clear, for the COVID-19 test. So, it's quite likely that you will need to retest those individuals. And I think ultimately you want to, their symptoms need to resolve. So their fever needs to resolve, their whatever constellation of symptoms. So if you have a symptomatic individual that's not found to have an alternative cause, you should act as if they are likely to be COVID infected and treat them as such, essentially. So you exclude them from school for 10 to 14 days, depending on the nature of the time available, and ensure that they're asymptomatic from the condition. Fever is resolved, symptoms are resolved for greater than 24 hours.
Okay.
And if possible, I would say likely retest them at some point to see if you don't have a better apprehension of what's going on because of the false negative rates.
Okay,
great. Thank you, Jennifer. Over to you, Sanjeev.
Yeah, I think, Kedar, you've talked a lot about ventilation and how the issue that I wanted to talk about is you must have seen the recent data coming out from some engineers saying these aerosols can hang out in the rooms for a lot longer than we had imagined. It's not hours, it can be many, many hours. And
right.
So the question then, of course, is that, of course, winter is coming and windows will be closed. What does regular air conditioning do? And can you put air exchanges in what is the impact of regular air conditioning? Of course, aeroplanes have these special filters, but how does that work out in schools, for example? Or in work environments, for that matter?
Yeah, there's been discussion about fitting HVAC systems with the relevant filtration systems that would allow for exclusion of much of the particulate matter that would lead to aerosolized material that would lead to infectious transmission. I don't know the literature, to be honest with you, about how that is working in school systems today. I do know that these are non-trivial expenses for systems, but it looks like Kent is also putting into the chat a link to air cleaners and HVAC filters that would be potentially useful to consult. But I know that so there has been discussion about this, that schools have been thinking about how to implement some of these processes and some of these fitting their HVAC systems with these kinds of purification devices. I don't know that there's clear guidance on whether or not this is a requirement or not, and whether or not it's affordable to do so for most school districts. So I would probably consult the document that Kent has just put into the chat at this time.
Another question has to do with the asymptomatic spread. So you talked about giving the infection to the teachers, but there's also the risk of giving it to their parents.
Yes.
And so how big is this issue of it? What's the latest on what percentage of people actually will be asymptomatic? And then what is the relative risk for them transmitting, and how real is that as far as current evidence is concerned?
Yeah, it's a very good question, and I was actually looking for the latest data on this to prepare for this, because I figured this question would come up. So thanks for asking it, and I don't have a clear answer for you. So it's a challenging question to answer clearly, because the ability to know whether or not an individual who's infected, the source of their infection, is a bit hard to understand, right? So whether or not it's the school-age child that's bringing the infection back home, or it's because the individual at home has gone out into the work environment, or being in a public place, or gone to the grocery store, or gone to the restaurant to eat, or whatever, it's very difficult to know precisely where the infection has come from, to be able to get to understanding of at a epidemiological level, to understanding whether or not the transmission events are occurring due to people being in school. There is data from Europe, again, from the early stages of European schools in many countries, resumed in late spring and didn't shut down altogether. So they shut down for a period of time and then reopened. And the question that was asked was whether or not that led to higher rates of community prevalence of the disease. So, and not at an individual family level, Sanjeev, I'm not answering the question at an individual family level, but at an epidemiological level, there wasn't a sense that the reopening of schools led to widespread growth in the community level transmission dynamics of the infection. So that's a partial answer to your question, but is not a, it's not a precise answer, because it's very difficult for epidemiologists to tease out whether the infection that's caused by the pandemic, by the school child coming back in with the back to the home, is due to that school child or due to the fact that the adults in the house are conducting other activities that might have also exposed them to risk.
Thank you. You know, there's a question about vaccines. I know there were several questions there, and I want to see, did you want to make any general comments about vaccine, Kedar, and the current, an update on what your perspective is on? I've just provided general update. We have lots of people from all over the world who would just benefit from the current state. Yeah.
Yeah, so there are a number of, as you all know, there's a number of candidate vaccines that are in late stages of development. I think there's 6 now that are in phase 3 development and trial. Vaccine is still seen as the, in many ways as a goal for us all to help to reopen more safely overall as a society. However, the enhanced procedures of infection control and masking and social distancing and hand washing that we talked about right at the start of this conversation are also going to be important regardless of whether a vaccine comes into play, because it will take time ultimately for a vaccine to be distributed, for us to achieve the levels of immunity that we need in order to prevent primary transmission events at a community level. So I think that we will see a vaccine in relatively short order. I've seen estimates. I know that politicians here domestically are insisting upon vaccine development sooner than later, but realistically, I've seen from a lot of infectious disease experts estimates around vaccine really being available in the early part of the new year. At that point, it will take, most of the vaccines that are available right now are being developed are 2-dose vaccines. So it'll require 2 doses separated in time. So distribution and coverage will be a big factor before we can achieve the level of population level coverage that we need to get to. Additionally, I think, in the meantime, I think all the processes around source control and social distancing and masking and hand washing are going to be critical for us to employ, even as and when a vaccine becomes available. And so, again, I think that vaccines are being held out as sort of the holy grail for reopening in general. But a vaccine strategy will almost inevitably sit alongside of a broader message around continuing to maintain social distancing and masking and hand washing, even as a vaccine gets developed and distributed around the world.
Yeah, I think there are other issues with vaccine which have to do with, we don't know how long the immunity will last, whether there'll be any side effects. There's also the vaccine hesitancy. The recent study, only 66% of the US citizens said they would take it if there was an effective vaccine. And then distribution, and especially, so I think the message is we still have to take control measures in a very significant way, even if a vaccine comes along, I think. And I think we've run out of time, Kedar. Let's go back to Matt to close the meeting, please.
All right, thank you, Sanjeev. Thank you, Kedar. To conclude today's session, we'd like to thank our presenter, Dr. Kedar Mate, for sharing his time and expertise today. And a special thanks to all of you for joining us today for ECHO COVID-19 Global Conversations. We hope you'll be able to join us for a special session coming up this Friday. It's outside of our usual Monday timeframe, and I'll tell you why. It's a session that's going to be hosted by the Chief Scientist of the World Health Organization, Dr. Swaminathan. And her team really wanted to bump up this talk to get the word out as soon as possible. We're going to be discussing what we've learned about transmission of COVID-19, all the latest science there. And there will be expert panelists from all over the world joining us for that to share what they've learned. So please join us. This will include panelists from the United States CDC, from China's CDC, and many others. So please join us. There will be a link in the chat. That's this Friday, September 18th. And we also hope to see you on our usual Monday timeframe for next Monday, September 21st, at the same time for cancer care in the time of COVID-19, with an international team of expert panelists joining us for that as well. As many of you might be aware, cancer survivors, patients with cancer, are distinctly vulnerable to COVID-19. So there will be plenty to discuss next Monday as well. There is or will be shortly a CME link available in the chat box as well for you to give us your session evaluation and receive your CME and CEU credit. And then please watch for email announcements and visit our ECHO COVID-19 Global Conversations webpage for any session updates and information. And again, thank you all for your continued interest in Project ECHO's special programming around COVID-19, and hope to see you all Friday. Thank you.
Thank you very much.